Okay, Karen, I'm going to start. Is that okay?
Please go ahead. Thanks.
All right. So I'm sorry, I just got to find the introduction. Okay, so good evening, everybody. Welcome to the Fellows Gecko for this afternoon. We're going to be talking about pouchitis, and Hassan's going to give the presentation. Firstly, Gecko is hosted by the Gastro Foundation in association with Project ECHO, University of New Mexico, and it's run obviously every second Monday at 1800 hours. The chat will be open for questions, so please post them, or otherwise, even better, ask me in person. So I'm going to let Hassan do his whole presentation, and then with them, you're going to have about 15 minutes to do the Q&A. Okay, so Hassan, if you want to start sharing your slides.
Hi, good evening all. Are you seeing my presentation nicely now?
Yes, we can see your screen and we can hear you.
If you could put your video on, please.
Okay, is it okay like this?
There you go. I can see you now. Thank you.
Okay, good evening all. This is me, Hassan Ali. I'm a medical GIT fellow at Leeds University, Charlotte McKinney Hospital. Today, I will present overview on pouchitis. Okay, during my presentation, we will have you talk about ulcerative colitis, familial adenomatous polyposis coli, why are pouches created, type of pouches, and ileal pouch anal anastomosis complication as a background for pouchitis disease. Then we will come across more detailed talk regarding pouchitis, starting with definition, epidemiology, pathogenesis, risk factor, going down to common mistakes and my message. Regarding ulcerative colitis is a disease, is a chronic inflammatory condition characterized by relapsing and remitting episodes of inflammation limited to mucosal layer of the colon. About 20 to 30% of patients with advanced ulcerative colitis will require surgical resection at some point. Regarding indication for surgical treatment for ulcerative colitis, we can categorize them in three big categories. First of all, those patients who need emergency surgery. For the patient with colonic perforation, toxic as a complication, for example, for toxic megacolon, or for those patients with life-threatening GIT hemorrhage, urgent surgery is indicated for acute fulminant colitis refractory to medical treatment. And elective surgery, it's indicated for patients with persistent symptoms and for those patients with high risk of malignancy due to long-standing disease. And the last one represents the majority of patients underwent this surgical treatment. Now, for familial adenomatous polyposis coli, it is a disease characterized by the presence of multiple colorectal adenomatous polyp, typically more than 100 for classic type, and between 10 to 99 for attenuated type. The prevalence is estimated 1 in 8,000 up to 18,000 in USA. Colorectal cancer occur nearly in 100% of patients if untreated. So the surgical treatment is indicated for those patients to prevent malignancy. Surgical treatment, which might be done laparoscopically or by open surgery, is a restorative proctocolectomy with ileal pouch anal anastomosis. This is the surgery which often performed for the patient with UC and familial adenomatous polyposis coli who require surgical treatment. Then, why are pouches created? In a simple talk, pouch is created to take over the function of the rectum. So, surgeon creates these pouches to restore intestinal transit and to take over evacuation function. Immediately post-surgery, most of the patients will have bowel movement ranging from 4 to 6 daytime and 1 to 2 at night, which might become totally normal after 1 year. To take dysfunction by the pouch maturation is required for optimum function. The pouch maturation occur by flattening of the villi, hypertrophy of the crypts, and increase in the pouch size. And it is important to know that we have different types of pouches with different configuration and length. And it's most important also to talk more about the J type. So regarding configuration, we have different types. We have J, S, W, K, according to the configurations that made during surgery. The J type is the most common type of pouches that created during surgery because it is easy to create, although there is some studies that the other configuration might carry lower risk regarding pouchitis, but it is comparable with the G type. So it's important to identify that for J type, we have tip of the J, then we have efferent limb, and we have afferent limb here, and we have pouch inlet. This pouch is created in a length about 15 to 20 centimeters. A lot of complications might happen in a patient with ileal pouch anal anastomosis. We can divide them into two big categories: acute complication and late complication. Regarding late complication, many studies demonstrate that pouchitis is the most common one, with the prevalence which might reach 80% after 10 years of surgery. So it is important, the most important one among the complications that we need to know and we need to study more about. Now, we are coming to pouchitis. So I'm starting by definition, and I want to say that pouchitis is an idiopathic, non-specific acute inflammation of the pouch, typically presented with increased stool frequency, which is more than 7 motions per day, and urgency. About up to 50% of the patient, the incidence of the pouchitis occur about 20 to 50% among the patient, most frequently among patients who have undergone total colectomy with an ileal pouch anal anastomosis for ulcerative colitis than those with familiar adenomatous bulbosis coli. No age predilection for pouchitis. From causative factor point of view, we have two types of pouchitis: idiopathic one and secondary one. For the secondary one, we label the patient. He has secondary pouchitis if there is a clear underlying cause, like infectious type, which might be caused due to Clostridium difficile, cytomegalovirus, fungal infection, or it might be due to inflammatory causes, like those patients might lately diagnosed with Crohn's disease or Crohn's-like pouch. Or other patient might develop autoimmune pouchitis secondary to IgG4 disease, and as well as few patients might have ischemic type pouchitis or pouchitis related to drugs, for example, like non-steroidal anti-inflammatory drugs. The idiopathic type that we are concerned about, there is no underlying etiology, clear underlying etiology for the disease. There is few hypotheses, the most popular one saying that it is due to abnormal immune response to altered luminal and mucosal bacteria in genetically susceptible patients. Regarding risk factor, we can classify risk factor for pouchitis in two big groups: risk factor, pre-operative risk factor, and post-operative risk factor. And we can see the degree and the extension of ulcerative colitis before surgery and the extraintestinal manifestation of ulcerative colitis before surgery and ulcerative colitis in a young patient taken as a pre-operative risk factor, as well as coexisting of other autoimmune disease like IgG4 disease, primary sclerosing cholangitis, as well as also drugs, for example, patient using corticosteroid and tumor necrosis factor before surgery, it might be taken as a risk factor for pouchitis. Any hematological disorder, previous surgery, like abdominal or pelvic surgery, may put the patient at risk of pouchitis. Also, obesity with a cutoff point of BMI more than 30, and the lifestyle for those patients taking, like, for example, low fruits, low vegetables, might put patient at the risk of pouchitis. Risk factor post-operatively, we have post-operative weight gain. So why weight gain post-operative? Because most of the patients will regain better function of their gut. So improvement in the gut absorption, decrease inflammation, increase appetite might put the patient at risk of weight gain, and weight gain might put the patient at risk of pouchitis. Fecal stasis and pouch configuration, again, non-steroidal anti-inflammatory drug use post-operative, presence of primary sclerosing cholangitis as autoimmune disease or reflux disease also might increase the risk of pouchitis post-surgical. Regarding the spectrum of pouchitis, it is important to emphasize that many patients with ileal pouches have some degree of chronic endoscopical and or histological inflammation. And it is important to say that this chronic endoscopic picture or histological picture not taken for the diagnosis. So pouchitis represents a disease spectrum with range of presentations that may evolve over time. Clinical presentation, pouchitis has variety of clinical phenotype. We can have acute or chronic disease with or without relapsing pattern. And regarding the symptom, patient might present, as we said before, stool frequency more than 7 motion per day is needed, urgency, hematochezia, pelvic pain, and incontinence, and as well as abdominal cramp. So pouchitis has certain characterization regarding etiology, response to antibiotic, and episode of relapses, which lead to different classification of the disease, which assist in guiding treatment. So it is important to consider these three elements because most of the disease classification depend on them. As we can see in this diagram, we can classify the disease according to the etiology. So we have conventional or idiopathic one if there is no underlying cause, or we can classify disease as secondary if the underlying cause is well identified. Regarding response to antibiotic, we have three phenotypes: antibiotic responsive patient and antibiotic dependent patient, as well as antibiotic refractory patient. Regarding episodes duration and episode number, we can classify patient to acute pouchitis if the disease duration is less than 4 weeks, or chronic pouchitis if the disease duration is more than 4 weeks, and we can classify the patient as relapsing pouchitis if the patient has 3 or more episodes per year. And for those patients who have less than 3 episodes per year, we classify them as episodic. And it is important to say that mixing between these classification to label patient is very applicable. For example, we can have patient with idiopathic chronic antibiotic dependent or idiopathic chronic antibiotic refractory. Regarding pouchitis activity, we have two forms, either disease in remission or disease or active disease. We use pouchitis disease activity index to score. It is a scoring system for assessing disease activity with cut-off point, 7 or more points. We use clinical parameters like stool frequency, rectal bleeding, fecal urgency, fever, and we use endoscopic parameters like endoscopic inflammation and edema. And we give 13 points for each parameter. If the summation is 7 or more, it is a cutoff diagnosis for acute pouchitis. Unfortunately, this scoring system used more in researches and it is less used in clinical practice. Recently, we have new scoring system from the Chicago group, with more clinical implementation and prognostic measures, and we will come across it during our talk. So regarding diagnosis, it is very important to know that the diagnosis of pouchitis is confirmed by 3 elements: correct clinical context, endoscopic finding going with pouchitis, and histological finding also going with pouchitis. So the correct clinical context are increase in stool frequency and urgency. And the endoscopic picture that goes with the diagnosis of pouchitis are diffuse symmetrical mucosal erythema, ulceration, and friability. Regarding histological, we have to demonstrate active inflammation plus or minus chronic inflammation. As I said before, it is a normal spectrum of the disease. So for the diagnosis, we need good focused history. It is better to start with the disease behavior and medication used before surgery, complication that the patient got after surgery, and the drug list of the patient. As we mentioned before, we know that non-steroidal inflammatory drugs might cause pouchitis, and the use of medication like tumor necrosis factor and steroid before it taken as preoperative risk factor for pouchitis. So then we have to demonstrate the right context clinical symptom that points towards the diagnosis of pouchitis. As we mentioned before in our previous slide, high stool frequency and urgency. Also, it is very wise and very advised to do good clinical examination, predicting the general status of patient well-being, to assess the degree of malnutrition, the complications that might affect other organs because of long-standing diarrhea, dehydration, and loss of appetite, and low food intake. And it is very advisable to do good perianal inspection and digital rectal examination, looking for fistula, fissure, dermatitis, which might direct the diagnosis in other direction. For example, Crohn's disease, as we know, usually present with these symptoms and signs. So it is very important also to mention that endoscopic examination and biopsy must be done properly with good reporting. Why? Because the correct diagnosis is merely confirmed by these elements, plus the typical symptom, as mentioned before. So we need to do good endoscopic visualization to demonstrate the typical mucosal changes, which are diffuse erythema, friability, granularity, exudate, erosion, and or ulceration, which is typically distributed throughout the pouch. Also, it is important to report and to describe the shape of the pouch. So now we know about the configuration in general, then the size and distensibility of the pouch. Most of the patients presented with pouchitis, they have decreased distensibility and flexibility of the pouch. The other important step is to take biopsies to be examined to complete the third element, the histology. And it is very advisable to take the biopsy from the pouch body and from the afferent limb, and to avoid biopsies from the suture line, because it might give us granuloma, which might direct the diagnosis on the other way, and it might lead to misdiagnosis. So during our endoscopic examination, mild mucosal changes like loss of vascular pattern and mild redness, as shown in picture A and B, it's not taken as a pouchitis. Whereas if we have endoscopic appearance of abscess ulcer, as seen in picture C, and erosions with shallow ulcers, as seen in picture D, this is taken as moderate inflammation and moderate pouchitis. For E and D, we have deep ulceration, and we have spontaneous bleeding, which categorize the pouchitis to be a severe pouchitis. So it is important to know all of this during doing pouchoscopy or endoscopy. So the Chicago group has new classification, as I mentioned before, to assess the activity of the disease. So it is a new novel classification system based on pattern of inflammation observed in pouches and evaluate the contributing factor and prognosis for each endoscopic phenotype. It is published recently in 2022. So Chicago classification phenotyping pouchitis in 7 phenotype endoscopically and demonstrates the importance of this type in the prognosis. So we have normal or afferent limb involvement pouchitis, or inlet involvement pouchitis, or we have diffuse inflammation pouchitis, and we have a focal type, we have caphitis, and we have pouch with fistula. And it is emphasized that diffuse inflammation and caphitis significantly increase the risk of pouch excision or pouch failure. And also, diffuse inflammation was independently associated with pouch excision due to pouch failure. Depending on this new classification, a multicenter cohort study done in China in 2023 demonstrates that diffuse pouchitis is a common phenotype of pouchitis that seriously impaired long-term prognosis. And for colorectal surgeon, decision-making regarding pouch construction with an appropriate lens should be considered to prevent the development of diffuse pouchitis. Why? Because it is clear from this diagram that the long J pouch has better prognosis than the short one. And as I mentioned before, the J shape, we might have different lengths ranging between 15 to 20 centimeters. So the third important element in the diagnosis is histology, which is characterized by acute inflammation, demonstrating neutrophil infiltration, Krebs abscess, and mucosal ulceration, plus or minus background of chronic changes. And we mentioned before, chronic changes, it is a normal spectrum of the disease that observed in a patient without pouchitis. So the other workup is complementary. So patient need to do full blood count, looking for iron deficiency anemia as a complication of pouchitis, electrolyte abnormality because of dehydration, which might affect the kidney and the kidney function, CRB to address the status of inflammation in the body of the patient, vitamin D deficiency, liver function test, and IgG4 to exclude other etiology of pouchitis, Also, patient might need to do stool studies, fecal calprotectin, lactoferrin, Clostridium difficile, stool culture, also to exclude other underlying diagnosis, especially on those patients with who have not well-defined clinical presentation or atypical clinical presentation, or they have atypical endoscopic finding. And also, we might need to do basic metabolic panel to exclude other causes which might cause diarrhea like thyroid dysfunction. Regarding images, which is only needed for patient with symptom suggested other pouch disorder, or in a patient with unsatisfying symptom or endoscopic finding, we can do CT scan, pouchogram with water-soluble contrast. We can do pelvic MRI. So regarding pelvic CT, the findings that observed in pouchitis are increased second wall or second mucosa with hyper enhancement as shown with the arrow, and we might have accumulation of peripouch fat as shown by arrowhead. So regarding differential diagnosis for pouchitis, we have infectious pouchitis secondary to bacterial, fungal, viruses. It is quite different from idiopathic one because if we did a stool examination and stool culture, we have a negative result for idiopathic type. Ischemic pouchitis, the main difference is in between it and idiopathic type is endoscopic finding. So for the ischemic pouchitis, it's characterized by asymmetric inflammation, whereas in idiopathic, we have symmetrical inflammation. And regarding ulceration of the pouch. Pouch prolapse, we find mucosal edema, erythema, and distorted pouch inlet. So because of that, it is important also to report the configuration of the pouch, as we said. Cuffitis, it is a circumferential inflammation of the rectal cuff with histological finding consistent with ulcerative colitis. So during the surgery, the cuff area, it is a transitional zone between the pouch and the anal bursa. So inflammation might affect this area specifically, and it might present with symptoms almost similar to the symptoms that patient with idiopathic pouchitis have. Crohn's disease of the pouch, usually those patients present with symptom and finding endoscopic similar to the luminal Crohn's disease, plus or minus granuloma on biopsy. Irritable bowel syndrome for the pouch, similar symptom, patient might present with diarrhea, but with normal endoscopic and histological examination, quite different from those patients with idiopathic pouchitis. Other differential diagnoses are non-steroidal associated pouchitis and autoimmune associated pouchitis. So now we are coming to our treatment. It's mainly for idiopathic type. For patient underwent colectomy with ileal pouch anal anastomosis due to ulcerative colitis. It is AGA guideline pre-printed copy. It will be published recently in early 2024. And it is important to say that recommendations are labeled as strong or conditional phrases. Recommended phrase indicate a strong recommendation, whereas suggested phrase indicate conditional recommendation. So generally speaking, AGA recommend treatment to till resolution of the symptom, whereas resolution of endoscopic and histological inflammation and treatment of asymptomatic patients are not recommended by AGA. For treatment of pouchitis, definitely we need general measures like rehydration, correct electrolyte imbalance, correct vitamin deficiency, because it's important for the patient well-being and for his general health. Treatment of acute pouchitis. AGA suggests using antibiotic for treatment of infrequent episode of acute pouchitis in form of ciprofloxacin 500 milligram orally twice daily for 2 weeks, or metronidazole 500 milligram orally twice daily for 2 weeks also. Combination between ciprofloxacin is metronidazole is also suggested if the patient, or if we didn't get a good clinical response. So we can combine both of them also for 2 weeks. Oral vancomycin is advised if the patient develop side effect from using ciprofloxacin and metronidazole. No superiority found between ciprofloxacin and metronidazole. Now, what is the outcome of antibiotic treatment for first attack of pouchitis or for episodic pouchitis? Most of the patients respond to antibiotic initially, but about 50 up to 90% of the patient will have episodic pouchitis, and we define episodic pouchitis by having episode of pouchitis less than 3 attacks per year. About 30% will develop chronic pouchitis in form of chronic antibiotic-dependent pouchitis. And we clarify this point that mixing between two or three classes or type is applicable to identify patient, or the other type is chronic antibiotic refractory pouchitis. Few of the patients will develop or will appear to have Crohn's-like disease of the pouch. These subtypes defined as follows. For episodic intermittent pouchitis, it is isolated and infrequent episode of typical pouchitis symptom that resolve with therapy, most commonly antibiotic, or spontaneous recovery followed by extended period of normal pouch function, typically months to years. For chronic antibiotic-dependent pouchitis, it is defined as recurrent episode of pouchitis that respond to antibiotic therapy, but relapses shortly after stopping antibiotic, typically within days to weeks. Usually require recurrent or continuous antibiotic therapy or other advanced therapies to achieve symptom control. Antibiotic or chronic antibiotic refractory pouchitis is those patients with pouchitis not responding to 4 or more than 4 weeks of antibiotic therapy. Fourth type is Crohn's-like disease of pouch, which is definition is based on the most common and accepted diagnostic criteria, for this disease, which include presence of peri-anal or other fistula that develop at least 12 months after the final stage of the surgery, or for those patients who develop a stricture of the body of the pouch or develop a stricture in a pre-pouch ileum. Also, the presence of pre-pouch ileitis might point to diagnosis of Crohn's-like disease of the pouch. Now, regarding treatment of these classes of pouchitis, recommended to be as follows. Firstly, to treat patient with chronic antibiotic-dependent pouchitis, AGA suggests using chronic antibiotic therapy to treat chronic antibiotic-dependent pouchitis, and it is advisable to consider doing endoscopic evaluation before starting treatment to exclude any underlying other diagnosis or to exclude in another way to exclude the secondary cause of pouchitis. The lower effective dose of antibiotic is advisable. For example, we can use ciprofloxacin, or it is suggested to use ciprofloxacin 500 milligram a day, single or split dose, with intermittent gap period, and cyclical use is very advisable to minimize the side effect of antibiotic, which might be used for a long time. Also, with the same regard to treat chronic antibiotic dependent, AGA suggests using immunosuppressive therapy to treat recurrent pouchitis, and we can use immunosuppressive in lieu of chronic antibiotic therapy. Regarding treatment of chronic antibiotic refractory pouchitis, AGA suggests using advanced immunosuppressive therapy, as well as suggests using corticosteroid. And it is advisable to use controlled ileal release budesonide. Short duration also is advisable, and consider of steroid sparing therapy for long-term use to minimize the side effect of steroid. But AGA suggests again is the use of mesalamine to treat chronic antibiotic refractory pouchitis. Recently, in 2023, Ernest study group published multi-center double-blind placebo study demonstrating that the effect of vedolizumab in treating patients with chronic pouchitis in compare with placebo. So they distribute 102 patients in two groups. 51 of them given vedolizumab in dose 300 milligram IV daily, and the other group given placebo. The result is quite informative that, or concluded that vedolizumab is more effective than placebo in treating chronic pouchitis. Because we can see we have two defined points for remission. The first one at week 14 and the second one week 34. So by week 14, 16 out of 51 patients developed remission in comparison with only 5 patients developed remission from placebo group. And by week 34, 18 patients out of 51 have had remission in comparison with only 9 out of 51 in placebo group. So it is taken as good outcome of treatment of pouchitis. And we can use it, as I said, in form of 300 milligram IV daily dose. Now, regarding primary prevention, AGA suggests again is using antibiotic for primary prevention of pouchitis. And regarding probiotic, AGA make no recommendation in favor of or against the use of probiotic for primary prevention or treatment of pouchitis, whereas AGA suggests using probiotic for preventing recurrent pouchitis. Probiotic usually in the most of the studies, no complication reported during by using probiotic. Maybe it's expensive, and we don't know for those patients who might need primary prevention for how long we need to use this probiotic. So because of all of this, it's not recommended for those patients as a primary for this patient to prevent them or to have a primary to use it as a primary prevention treatment. But it is suggested to be used for recurrent pouchitis or chronic recurrent pouchitis. The role of probiotics, it is well clear. It enhances, as we see here, it enhances the epithelial period of the gut mucosa and increase adhesion to the intestinal mucosa. Plus, it has function in inhibition of vasogenesis adhesions. So by this adhesion, it minimizes adhesion of vasogenesis, which might affect the mucosa. Plus, it has competitive exclusion of pathogenic microorganisms that attacking mucosa. And as a prophylaxis of Pouchitis onset with probiotic therapy, a double-blind placebo-controlled study done using BSL-3, and it's quite clear that for acute Pouchitis, we have a good result to prevent acute Pouchitis, especially after 1 year of treatment. And as I mentioned before, it's expensive drug, and using it for 1 year, it might be a little bit not applicable. So for treatment of Crohn's-like Pouchitis, AGA suggests using corticosteroid, preferred controlled ileal release budesonide, again for short duration, and we can use also, or advisable to use, steroid-sparing therapy for long-term use. Endoscopic evaluation of the pouch to confirm Crohn's disease and to exclude other diagnoses also should be considered. Also, using advanced immunotherapy is suggested by the new AGA guideline as a treatment for Crohn's-like disease. Now, regarding one of the differential diagnoses presented with similar symptom to idiopathic Pouchitis, which is Couchitis. So we can define Couchitis as inflammation at the anal transition zone, which created as a result of ileal pouch anal anastomosis surgery. For its treatment, AGA suggests using topical steroid topical therapies in form of mesalamine or corticosteroid as a first-line treatment. And also, it gives us suggestions that use of immunosuppressive therapy for refractory Couchitis is recommended. So, what do other guidelines say? Last guideline published with this regard was published in 2017 by ECHO. And we can see that the recommendation for treatment of acute Pouchitis is consistent with the new recommendation that we have from AGA now. ECHO guideline did not explicitly provide recommendation on primary or secondary prevention of Pouchitis, role of chronic or alternative antibiotic therapy, and she didn't give us role of immunosuppressive therapy as treatment for chronic Pouchitis or refractory type. The management of Crohn's-like disease also is lacked in ECHO guideline. And now we have all these elements fulfilled in the new guideline. So the future direction that we needed for this guideline, we need more standardization of the disease entity, more study and address of natural history and risk factor for inflammatory disorder of the pouch, as well as we need more clinical trial design in Pouchitis to give us more detail and more good result that we can depend on during treatment and diagnosis. Here I want to mention that chronic inflammation, continuous inflammation, at the end the patient might part into pouch failure. So simply pouch failure means that his pouch not function. There is a recent study done in 2022 or published in 2022 addressing the prevalence of pouch failure of ileal pouch in ulcerative colitis. It was a systemic review demonstrating that the overall prevalence of pouch failure is 6%. And this result it's important, especially for the surgeon to be considered meanwhile they are counseling the patient undergoing the surgery. And also, I think we have to consider the risk factors that we mentioned. Generally, treatment of pouch failure, either by doing permanent diversion or removal of the pouch. So, some mistakes in the field of treatment or diagnosis of idiopathic Pouchitis and I want to talk about is assuming all pouch dysfunction is primary idiopathic pouchitis without excluding alternative diagnosis. Then missing pelvic sepsis as a cause of pouchitis, because if we didn't treat pelvic sepsis, we cannot get good result or good outcome. Not systematically assessing and reporting all pouch region endoscopically, and we came across this thoroughly in previous slides. It is a very important point because endoscopic examination and biopsy taken to have histological examination is extremely important to diagnose pouchitis. Failing to appreciate the impact of symptom on quality of life, it's important to consider this, because a lot of patients might have poor quality of life because of recurrent infection, recurrent symptom, and even it might affect their psychological status. The other point that I want to say, not recognizing the presence of cophitis. Cophitis is, as I mentioned, it is one of the differential diagnoses, but it presents with symptoms almost similar to the idiopathic type. And the main difference is by endoscopic finding. So as we mentioned before, there is a certain area of inflammation, which we mentioned as a transitional zone with the normal rest of the pouch examination. So it's important to consider cophitis. Labeling the diagnosis as Crohn's disease when the feature may be due to another etiology. Also, it is important because we might park onto treatment of immunotherapy, immunosuppressive therapy, or steroid, and all of us, we know the side effect of this medication. Commencing biologic without fully reassessing and diagnose the patient. It is very important to reassess the patient before biologic use. Number one, to avoid misdiagnosis and to confirm that we are part in a correct diagnosis. And because we know that the biologic side effects are a lot, and the patient might suffer from these side effects. Also, failing to reassess the patient regularly when they are taking long-term antibiotic, because antibiotic might give us a lot of complication. Simply, we might have diarrhea because of long antibiotic use in form of Clostridium difficile. So it might be confusing. Is it idiopathic pouchitis or is it antibiotic problem with the pouch? Failing to optimize diet and fluid intake. So it's important because patient might develop dehydration. He might be emaciated because of low intake, because of catabolic status of the patient, because of the inflammation going on behind. So it's important to consider diet, and there is a certain diet which might improve the pouch function, like vegetables and fruits. Sorry. Maintaining patient with pouch dysfunction out of the specialist center. Very, very importantly to manage the patient in the specialist center. Especially, we don't have good experience because we don't have large number of patients to be diagnosed and to be treated. So it is better if we have a specialty center regarding pouchitis. It's better to treat patients there. So my message will be the endoscopic picture of pouchitis, because it is very, very, very important to know and to appreciate the finding during pouchoscopy or endoscopy, and to know how to take biopsy from the pouch. It's extremely also important to part on correct diagnosis. So I want to demonstrate some finding during endoscopic examination. So for picture A, we have the green arrow pointed towards the tip of the J. It is important to be examined and to be demonstrated and to be reported in our report. Also, it is important to examine the inlet of the pouch. Generally, this is a picture of normal pouch or healthy normal pouch. For picture B, it is chronic pouchitis. It is clear we have symmetrical inflammation of the mucosa, stiff pouch, loss of frustration, almost pipe-like. So this is a picture of, this is a typical picture or the typical endoscopic picture of pouchitis. For picture C, we have ulceration, but it is quite clear it is focal, not symmetrical. So this is not idiopathic pouchitis. This is ischemic type pouchitis. Also, we might have complication due to chronic process of pouchitis in form of polyp, as we seen here arrowed by the red arrow. Also, for picture A here, we have chronic pouchitis with concurrent distal pouch sinuses. And as we mentioned, that the new classification classify the patient with complication with and developing sinus, the Chicago classification. In P picture, we have P and C, we have diffuse pouchitis and enteritis with a similar mucosal pattern in a patient with primary sclerosing cholangitis. So we have to take care and to differentiate. Anyway, if we take a proper right biopsy, it will differentiate. For D picture, we have chronic pouchitis with Clostridium difficile infection, and we have a little bit focal with pus lesion seen here in this endoscopic picture. So these are my references. Thank you for listening.
Thank you, Hassan, for an excellent presentation. It was very, very thorough and very accurate. Yeah. Okay, so there are just a couple of things that I noted down during your presentation. I don't see any questions in the chat yet, but hopefully somebody will ask something before I'm finished. So you mentioned the long-term complications of ileoanal pouches, and you mentioned that pouchitis is, of course, the most common complication, but we must not also forget about colorectal cancer. Okay, and the risk factors for colorectal cancer in a pouch are patients who've had their colectomy either for dysplasia or established colorectal cancer. Those patients who have primary sclerosing cholangitis, because we know that their risks are much higher anyway, as well as patients who have severe atrophy of the pouch. You didn't touch on it, but when the histopathologists report on pouchitis, they will often grade the degree of atrophy that you see. And if there's severe atrophy and inflammation, that is an independent risk factor for colorectal cancer. And it's very debatable exactly how often one should screen patients with a pouch. Probably every year if they've got those risk factors. But if they're low risk, I'm not even entirely sure they need to be screened at all, to be honest. Okay, so then something you sort of touched on in your last slide. If you have a patient who's antibiotic refractory or has recurrent bouts of pouchitis, you really need to think about pelvic sepsis. Okay, this is something our surgeons are really big on. And before you start throwing repeated courses of antibiotics at these patients or thinking of moving on to more aggressive therapies, you need to do a CT or an MRI of the pelvis, just to make sure you're not sitting with something outside of the actual pouch that's causing trouble. You mentioned VSL-3. So this is a probiotic which is actually been evaluated in randomized controlled trials. They were very small studies, not the best quality, but they did seem to show a benefit. It is a probiotic that consists of, it's either 5 or 8 different strains, I can't remember offhand. It's used to prevent recurrent bouts of pouchitis, not to treat acute pouchitis. And you're right, it is expensive, but we do actually have it available to us at Groote Hospital. In terms of more advanced therapies, you mentioned the earnest study of vedolizumab, which was quite promising. Just bear in mind that the numbers in both the vedolizumab and the placebo arms were very small. Okay, but of course, it's an option, and at least there is a randomized controlled trial to back that up. Tofacitinib, which of course works very well in ulcerative colitis, doesn't seem to work in Crohn's. There are really just case reports of its use in pouchitis. And similarly, with ustekinumab, there is data, but it's mostly small retrospective cohort studies. Nothing on a major scale has been done there. Then I also think, the surgeons generally do the counseling with patients before they have their pouches, but I think patients' expectations need to be realized. They need to understand what they're getting themselves in for. Firstly, a colectomy and an ileoanal pouch is not a cure, and one must never use that word cure with patients, because when you say the word cure, you are implying that you're getting somebody back to their pre-morbid condition. And 4 to 6 loose stools a day is not normal. It's extremely unpleasant. In fact, our surgeons are moving wherever they can away from doing pouches because they just find patients are pretty miserable at the end of it. And they're often a lot happier just keeping their stoma, to be honest. Okay. And then just finally, an experienced colorectal surgeon must do pouches. They must only be done in centers of excellence. There's a steep learning curve for these. You only get one shot to put a pouch in, and it really should be done by the very best person that is available. So I don't know if anybody's got any questions. We're sort of out of time. Mash and, okay, yeah, Mash. Yes, you're asking, is VSL3 the same as the Simone formulation? Indeed it is. It is. I like to call it VSL3 because I don't know how to pronounce that person's surname very well. Anyone else? Any other comments, chats? I'll just make sure there's nothing that I've missed. No, but don't think so.
Hi, Snail.
Hi, Mel. Yeah, please comment.
Yeah, just to thank Hassan for an excellent presentation. I do remember we once presented a patient of ours who had pouchitis, and Mashiko mentioned hyperthyroidism as a potential symptom trigger. So I think that's one thing to consider. And I mean, you're right. So where we work, the colorectal surgeons here do not do much of pouch construction. So I think that's why, probably our fellows have not seen actual pouchoscopy, which it is important to know. And also, as a gastroenterologist, you need to know how to describe pouch findings. And I'm glad that Hassan actually showed the pictures and what different parts of the pouch are termed, because as gastroenterologists we have to be at a certain level when we do our endoscopy reports. Yeah, but definitely I don't know, I guess I can't even say we can consider ourselves an expert center when it comes to pouches, because they're just not being constructed.
I agree. I think the surgeons are really off them because they're problematic. They're not happy patients, and when they come back, they're not smiling. They just really aren't. So Okay, well, I think in that case, I'm going to close the meeting. So let me just say my thank yous. Just to find them. Okay. All right. So first of all, thanks to Hassan for an excellent presentation. And on the chat group, there are a number of very complimentary comments about your presentation. So well done, your colleagues. And I really enjoyed them. Okay, thanks to ECHO University of New Mexico and ECHO India. Thanks also to obviously Karen and the team for all the support. The recordings will be available on the GI website. And of course, thanks to the Gastro Foundation. And our next IBD presentation will be in 2 weeks' time on the 16th of October. And this will be perianal disease and fistulae. And Nassif Fandaskay from our unit is going to be the presenter. So good night, everybody. Have a good evening. And I'll see you in 2 weeks' time.
Thank you, Prof. Thank you for everyone. And
Thanks,
I would like
Gill.
to thank my department as well.
Cheers, everybody. Bye.
Bye.